Hello, welcome to Please Continue, I'm Listening with Dr. Catherine Hayward. I'm thrilled to introduce you to Dr. Adam Rindfleisch and Dr. Bill Manahan, both physicians, educators, and co-founders of International Integrators and Living Whole Immersion Retreats. Bill, Adam, and I have known one another for decades, each of us working within the conventional medicine system in the U.S. to bring a more integrative, whole health approach to the systems within which we worked. Bill in Minneapolis, Adam in Madison, Wisconsin, and I in Boston, Massachusetts. As three old friends and colleagues, Bill, Adam, and I bring to this podcast some of the themes that we've talked about for years as we work toward improving future health education and care for budding doctors, nurses, and everyone interested in health and healing. We had our conversation during the pandemic, so please excuse the Zoom limitations. Adam's leadership in integrative whole health includes positions in academic medical education in Wisconsin and Arkansas, and in the Veterans Health Administration. Bill is Assistant Professor Emeritus in the Department of Family Medicine and Community Health at the University of Minnesota Medical School, and is past president of the American Holistic Medical Association. I regard Bill as one of the preeminent pioneers of the integrative medicine whole health movement in the United States. So, Adam and Bill, please continue. We're listening. So I'm here with Adam Rindfleisch and Bill Manahan. Very, very happy to be with both of you, colleagues from many years. Both of you were part of International Integrators when we first got started and helped us come up with our definition of integrative whole health, which brings together the best in conventional medicine and whole plant-based food and movement and mind-body-spirit disciplines. And now we are expanding our mind-body-spirit disciplines beyond the energy practices that we usually include in our Living Whole in-person retreats and also our online experiences. And we're moving, in addition, into the arts and music and writing and literature, filmmaking, photography. And so I'd like to start by asking each of you to talk about why you think this approach to health and healing is so important right now during the challenges that we're living through.
Go ahead, Adam.
A few things come to mind. One is that, especially with the COVID pandemic, we're realizing just how important it is to think about every aspect of self-care, both for people who are trying to prevent problems and dealing with problems and, the whole sort of post-COVID syndrome as well, right? And that's certainly not something that you can do with just a conventional model necessarily, because so much of it's tied to self-care practices and so much of it is tied to exploring for a disease that we still know very little about, what sorts of options are available. So I think there's really room for a more whole person perspective in that regard. And I think we're going to continue to find, and this is important even at baseline, but this idea of interprofessional, interdisciplinary collaboration with all of this too. We're just, healthcare is complicated, chronic diseases are out there and continue to be on the rise. And I think everything we can do to sort of make the healthcare system more flexible and transformed to kind of meet those needs is going to be really important.
Yeah, I agree. And looking at the history, until maybe penicillin came along, better surgery, all those things, pretty much people got sick, and their health depended on how healthy they were, because the medical system did not have a lot to intervene with that made a big difference. And then it's like how pendulums go. It swung way to the other side, and we sort of got that medical care would take care of us. It didn't have much to really do with our health, our individual health, or even the health of the nation. It had the medical system would swoop in and do amazing things. And I think in a sense, what the pandemic and what this time has done is helped us to realize that, like most things, we need some middle balance. Yes, at times, naturopathic and chiropractic and medical intervention can be incredibly helpful. But at the same time, we're now realizing that the whole health of our planet and of our individuals and of our groups is really what's going to make the difference in how healthy we are. Which I like. Why whole health? It's not just about the individual. If we don't look at the planet, it won't matter how healthy how well we eat, a plant-based diet and exercise and have good relationships. And so it's the whole health of all of us and everything. Why I like what we're doing.
Well, one of the many reasons I was excited to talk with both of you today is because all three of us were trained in conventional medicine, and all three of us have had long careers in the conventional medicine system, and yet all three of us, sort of on separate paths, came to a more whole health approach. So I'd love to have each of you just describe your personal journeys along that path.
That's always a winding tale, but I think I didn't certainly learn it in medical school or residency. I think more I learned it from a combination of my patients having experiences that their illness had direct causes to their lifestyle, and then in my personal life, same type of thing. And with my patients, and a clear example was when I started in the 60s and 70s, type 2 diabetes really didn't exist. And when I talk to medical students about that, they know I either missed it or I'm lying. And I go, no, I got a lot of blood sugars, and type 2 diabetes was so minimal. And that's an example of how whole health living would just change an entire generation. As our planet and as our individuals got less healthy, type 2 diabetes just sprang into this incredible thing. So, and then in my own life, I had a couple of instances where I had significant problems, which I've talked to you two about with my Meniere's disease. A significant illness that was really debilitating. And it was things in my life that were causing me to have the Meniere's disease, the dizziness, the symptoms, the problems. It related more to the stress I was under, the anger I was feeling, the other things in my life. So I see now us hitting that sweet point of, at one point, we depended totally on the body. There was very little medicine. And then we got our head shifted these last 80 years with sort of the incredible advent of all the medications and surgeries. And now I see whole health is coming back to understanding. It's why I like the word holistic rather than integrative medicine. Holistic is whole and healthy and holy. And that's where I see us in this sweet middle spot coming with what the whole health work that you're doing, Catherine. It brings us all into that, yes, medical care and naturopathic care, that's important. And we have to really work with the planet, with ourselves, and with our groups and with our towns to live a more healthy life.
Yeah, I so agree, Bill, that you need to think about it at every level. And I love seeing, a lot of medical schools are starting to talk about taking things from the level of genes all the way to the level of society. I think that's really important to do. Yeah. For me, it was similar. There were just a lot of lessons there about this is important, and what we learn, with the scientific aspects of all this is really important and essential, and of course can save lives. And it's not always the whole picture, right? Sometimes we focus so much on the physical as kind of the fundamental part of it all, but it's just the tip of the iceberg, right? And you have a person's mental and emotional and spiritual and social health, and you've got to think about their story, and I think importantly you have to think about that story in terms of how do you individualize care for them. And so a lot of the most powerful experiences I had, moving through my training and being a family physician really came through that, and it felt like it was a natural fit, and I had a very supportive residency experience and beyond where it felt like there was room to build bridges any direction you needed to go, as long as you were thinking about, what is going to help this person who needs it the most. And personally, I found that to be the case. There were just often times where and I think this is true for a lot of folks, especially who work with kind of a whole health kind of perspective, is you have these transformative experiences that lead you into this. And then you feel this commitment to bring about transformative experiences for others, because if it can help, great. And frankly, it tends to be safer than a lot of the other options that are out there, and so being able to be mindful of efficacy and safety and what an individual wants and needs can be really powerful. And it was certainly the case in my own experience, and a real gift to be able to offer when you can to patients, clients, people.
I think that's the key idea. And one of my early examples of that was I was treating this young 14-year-old quite nicely for his asthma. And I thought I was doing a good job. And for a year, giving him the usual pills and stuff. And then I made a house call to the house because another child was sick. It was closing time. They were on my way home. And I went into the house and went into the bedroom. And the house was really moldy. It was a family that was quite poor. And they had moved in 2 years ago to my town. And I by this house call, because I could even smell the mold as I got in the house. And then I got to the bedroom where the child was, and went, oh. And I got a public health worker and some help, and we got the house run out. Well, I saw that person. He ended up going through high school, through college, and became a doctor. And he never had another asthma problem. And it was one of those things about a year or two later, because I saw him for a sports physical in like ninth grade or something. And I said, how's your asthma? He said, I don't have asthma. And I assumed maybe he'd gone to another doctor or something like that after getting rid of the mold. And so talk about whole health or going upstream. Because we do some things in Western medicine so well, that we then think we can do a lot of things well. And if you have a heart attack or a broken bone, it's not real important at that moment to go upstream. But all the chronic problems that we now see. I saw an interesting statistic, and I don't know if it's right, but last year I saw the statistic. It was a pretty good source, but that there used to be something like 30% of people had a chronic problem. And now it's like 60 or 70%, or some. If you're over age 30, is that similar to what you've heard? It's Adam was shaking his head. Yeah,
it's up there, and it's really
it's gone
quickly.
Crazy. Yeah. And I know that from in the 60s, so much of what we did was acute care. Mm-hmm. It was fast medicine, and now most doctors don't even see acute care because they go to urgent care ERs, and all they see is slow med. Their whole practice is chronic care.
Yeah, it's really interesting. You can actually go to the Centers for Disease Control website and just type in chronic disease statistics, and it'll show all those numbers, like how many people have chronic disease and how many people have more than one, which is a rapidly increasing number too. It's really sobering, and so it takes you back. Yeah. How do you work with that? And I love, Bill, when you're talking about surroundings, as an element, as the environment around you, and being able to kind of know what's going on in a person's home, and needing to get the buy-in of their family, their household, and all those different pieces that come into play. I've been really struck, the VA with their whole health work over the last 7 or 8 years, they've been starting to get data coming out, and I just heard that they'd reached about 347,000 people with the whole health education that they're doing now. And when they look at veterans who've been through the whole health training, they see drops in opioid use, they see drops in ER use, they see drops in overall cost per person and pharmacy use, So it becomes this amazing way of kind of, well, I mean, the words that they use are empowering and equipping, and I think there's so much power to that, and I'm really excited to be able to bring that more, with this work I'm doing with the whole health-based medical school, really start to bring that to bear, hopefully even in addition to the VA work, because there's so much power to it.
Can you talk to us about the Whole Health Medical School?
Yeah, sure. So just this past year or so, the Whole Health Institute was founded. It was founded through Alice Walton and the work that she's doing to try to bring whole health to all people in all communities. That's really kind of the mission. And with that, there's been a real need to start building up medical education in Northwest Arkansas. So the agreement has been that in order to do that, it would be great to have a whole health medical school, and not just a medical school, but ultimately an interprofessional training program, so that all the members of the team are being educated about whole health and in this model, and doing it in a way that's absolutely evidence-based, and doing it in a way where it's very respectful of all the things that students need to know in general, basic sciences and all the rest. But then there's that something else too, and I think that something else is what we've been talking about. How do you look at the whole person? How do you build care about what really matters most to a person? Because you're much more likely to have them engage if you do. And then one piece that I think gets left out in a lot of medical education sort of curricula, which is taking care of yourself along the way, the care of the caregiver, and being able to apply that model to yourself and live it, kind of that whole walking the walk, not just talking the talk piece. So yeah, the hope is to get it all sort of laid out, new facilities and everything, and then we'll have the first class come in fall of 2024. And so kind of start building from there with this idea that everything that they do will have the whole health approach woven in from the get-go, so that hopefully we're kind of creating leaders and teachers and trendsetters for how healthcare can look in, well, the 2030s especially.
In a sense, Adam, I'm so excited about that because I a little bit of I don't know. But it feels to me like what it's done is take the HEART program that we had for fourth year students and made it into a medical school. And that because, I've been so discouraged that after 20 years or more, nothing has happened. And yet every senior medical student who takes our HEART program says it's the greatest experience of their whole 4 years of medical school and 3 years of residency. And here you're in a sense doing that. And I think that's the biggest thing about whole health. And it's not really blaming anybody. It's that the changes we made in ability to change physical things with human beings has been so huge. And I still, in my family, like someone I can remember in the 60s and 70s having a bunch of the farmers coming in with really bad osteoarthritis. They could barely walk and their hips were, bad. And there was not much to do for them. The surgery for putting something in the hip was not that good. And when hip replacements and knee replacements came along, it was like gold. And it is why, we've sort of, like anything that's good, it's like, well, too much of too good can be too much. And it's what happened. We got so good with certain antibiotics and certain surgeries and doing it. And I think the whole health to me, if I could just say one more sentence here, we so much in all the training of Western medicine was about the physical and then lip service to the mental. But we didn't look at all at the social, at the environmental, at the lifestyle, at the spiritual. And that's what whole health is. And that's what your new medical school is going to be. It's going to be truly looking at who we are as human beings. We're not just physical beings. We're spiritual beings and environmental beings and social beings and, this other thing. So I think we're at a point as big as when when allopathic medicine sort of took the course 100 years ago, where, that's a century is enough, and we're now going to move into a whole nother era. And I think you two are truly leaders of that with the programs, the medical school and the program you're doing, and Catherine.
Thanks, Bill.
Yeah, it's big. It's big stuff.
Let's talk a bit about energy. Sometimes in some circles it can be a word that we're a little reluctant to use, but it's a very important part of what Bill's alluding to in terms of the future of whole health. Could each of you talk about your view of how we work with energy in health and healing, and where you see it fitting into what we're doing now and where we could go?
Go ahead, Adam. I'll let you take that one first.
Sure. Well, it's interesting. Back in the day when the NIH opened up the National Center, back then it was for complementary alternative medicine. They kind of had different categories of ways to do things. And initially, they had a category for energy medicine, and they had different types of energy medicine classed under there. And there was a real backlash, right? There's a lot of challenge with that because mechanism of action isn't completely clear. There are a lot of different conceptualizations around it. And I think for a lot of people, it really pushes a lot of buttons emotionally. It's hard, I think, my observation over the years has been it's hard to be objective about that, even though I keep hoping that scientific methodology, all the rest of it, really would kind of allow you to take on any kind of question or challenge from that more, well, let's explore this kind of a standpoint. But it's been kind of fraught over the years. I see that that's kind of settling down a little bit more now. In some ways, I know of programs now that are starting to cover, various biofield therapies or whatever you want to call them as part of coverage for patients. You see more and more, for example, healing touch programs going into the hospitals and so on. From my perspective, I think there's a lot of merit to exploring that. I think people can do very well with that, and it tends to be incredibly safe for people. You've got to be careful not to, if you're having an acute need, it may very well be better to go to the ER, right, than to kind of seek some of these other approaches right away. But in terms of doing work and going deeper, than just that, very important, but not isolated physical level of who a person is. I think there's some real power to it. And my experience over the years is that it really can be very helpful for a lot of people. And so, anytime that I can find a good way to incorporate it that feels appropriate, I'll sure be open to that.
Well, and before Bill answers, Adam, you ran a program that you alluded to a minute ago at the VA for the past several years. And when you first started that, I remember being really surprised to imagine that the Veterans Administration would be open to energy practices and the sorts of things that we're all drawn to. What was your experience during those years in the VA with regard to energy work?
Sure. Well, it's really interesting, right? Because we had the chance to teach all around the country, wherever there were different VAs, it's fair game to be able to go there and teach. And it was really fun to see how different groups worked with that. So the VA has what they call List 1, which are things that are covered within the VA, and it includes acupuncture. Still a lot of exploration going on about what exactly the mechanism of action is for that, right? There's massage for pain. They cover a number of mind-body approaches, biofeedback, hypnosis, guided imagery, and so on. And then they cover yoga and Tai Chi now. And of course, Tai Chi, at some level is that a lot of discussion around how the movement helps facilitate healthy energy, right? So it's really fascinating to see that covered. There's also, a very open-minded approach to other things that may not be on that list and specifically covered, but if sites want to explore how to bring them in, okay. And there's a really large movement out there, especially among nurses, and this is beyond the VA and all health systems, where you're trying to bring things like healing touch or Reiki or some of those kinds of things in is really interesting and important and something that folks are exploring. And it's done in a lot of different ways, but what I love is just leaving room for it. The only way we can find out how well something works is to have room to try it out and to study it. And it seems like there's a little more space for that now, which I really appreciate seeing. And we learn and we keep evolving based on what we learn. And my attitude is if patients are doing better and we see that and they're safe, then it's great to be able to give them options. Again, empowering and equipping, right? And so what does that look like?
I'm so glad you mentioned nurses, because my experience has been that the nurses have been in the forefront of a lot of this. And I have a cousin who is in her 80s now, but she was telling me that it was part of their nursing training and part of what was expected of them during a shift to give a massage to each of their patients twice a day, twice a shift.
Mm-hmm.
A massage, a body massage in the hospital. That ended before I started practicing. Bill, do you remember that was part of things when you first began?
Yeah, and of course, yes, I do. And of course, the nurses were the beginners of healing touch, which is, probably one of it probably has helped energy healing, energy medicine to get status more than anything else. When suddenly tens of thousands of nurses were doing healing touch, and people go, that have been problems for a long time, 1 or 2 treatments, and suddenly we're better. And so the whole, then when acupuncture started coming into the country and acupressure, and so, and both Adam and I have been huge as MDs. We've been, and you, Catherine, we've all been big, proponents and backers of energy healing, energy medicine. And I think it feels to me, basically we live in a quantum universe or a quantum field, and there's more and more talk about that. And I think that that invisible field of energy and information that is the quantum field is basically, we're learning, oh, that's real stuff. That this is not woo-woo, it's not crazy. And so the whole idea of that we're energetic beings in an energetic field, in the quantum field, I think energy healing will be as big in many ways as our physical healing is now.
Yeah, so, for the three of us, we've been thinking about these subjects for a long time, many years. We've had lots of discussions over the years. Some people are going to come to Living Whole Online, and they're going to be quite skeptical of this
Sure.
kind of stuff. When you encounter someone who's skeptical of the idea that there is something beyond the conventional medicine system that could help them with healing and health, how do you speak with that person?
Mm-hmm. Well, I think it's so important with all of these topics to be able to meet a person where they're at, and not to go into it like I have all the answers and I'm going to convince you or something. The thing I love about the whole health approach with the idea of, asking people what really matters to them and guiding care accordingly is that you can kind of talk about it in terms of their values, right? Instead of trying to say, this is the way it works. It doesn't work. I mean, we know this, right? 50% of medications are somewhere in that neighborhood aren't taken as prescribed, and so it works all sorts of ways. When someone else tells you what to do, imagine that. People aren't always big fans of that. And so if you're an active part of the plan to determine, there's a lot of room for all sorts of different possibilities. I think it's good for people to be skeptical. I always try to maintain a certain amount of healthy skepticism too, because there's a lot we don't understand. And if you look back 100 years, some of the things that we now do routinely, like washing our hands or whatever, our 100 plus years, are just part of what we do now. And I think 100 years from now, that could very well be the same thing. That there are a lot of things where we do things that we would never have imagined that we'd be doing. And so I think just having a healthy skepticism, but leaving room for people to explore things for themselves and to support them along the way. What is really hard for me, and I think more of the research has been done in the line of dietary supplements, but they'll survey people and they'll say that they don't bother to tell their clinicians about their use of certain things because they don't think their clinicians will have anything helpful to offer and they don't want to be judged. And so what a horrible situation if you're trying to be the person who's the go-to person for this person's health, to support them along the way, and they're not even telling you what they're doing because they don't trust in your knowledge base. my attitude with all of this is that regardless of what a clinician's personal views are, we should be able to have intelligent conversations about all these things. Whether or not you think supplement X or energy medicine approach Y is helpful based on your experience and so on, you need to be able to help folks out. And in order to do that, my attitude, and when we work with fellows and students, is you should really explore some of these things for yourself. You should learn about them. You should ideally have some experiences with them if you're comfortable with that, just so that you can speak from experience and not just make it all kind of an intellectual exercise or whatever, and so I think that part of the importance with working with skeptics is, number one, to be knowledgeable enough that you can have a conversation. Number two, to be open enough that you can respect the person's perspectives and opinions. And number three, just familiar with, I guess, how to build a continuity relationship with someone so that over time, maybe there's room for more exploration because there's trust that's built up both directions. And that's really important too.
I really agree with that, Adam, and I think that third point for me was the most important. It's why I think we need many more primary care doctors in general internal medicine, pediatrics, and family medicine. Because what I found, if it's the first or second visit, I didn't try and convince them of anything, because I don't trust them and they don't trust me. In a sense, we're new, And so it was like, okay, and I can remember many times talking to someone about, going on an elimination food diet or trying to say some positive chants or do just different things I do. And the women in generally would be quite receptive, even on the first or second visit, just getting to know me. But the men almost universally would say, Doc, just give me a pill. And I hate to be so stereotypical, but it was really interesting, sort of the difference of that. But then the longer I practiced and the longer I knew the men were, they started to trust me and would do many, they would go see dietitians and they would do the elimination diet and they would do different things. And so, and it's one of the really sad things I see now, how when systems take over, even primary care clinics, they don't honor really that whole thing about primary care. And when I have a primary care doctor and I called to get in the next couple of days, well, she was all booked up. And so on. They kept saying, well, you can see her partner. I said, I don't want to see her partner. I want to see my doctor. I've known her for 10 years and she knows me. And what I know is it's going to be a lot better care from her than even if I see the superstar doctor at the clinic, because 2 or 3 studies have shown continuity of care with the same person is far more important than how brilliant you are as a doctor. It's a matter of trust and everything. So it's something that, again, I hope we can look at the medical system and say, we really need to look at doing better continuity of care. We're not honoring it. Systems don't do a good job of it.
Well, and I think that's part of the beauty of individualizing care right there. I mean, sure, there are the trends, right? Like in many families, there's one person who's the main kind of healthcare shopper, and it's often, a woman. But of course, now with family dynamics changing and everything, you have to know the family in order to know who's the kind of driving those decisions and who's in the family and how is all this being determined, and recognizing that continuity relationship and knowing what drives folks is going to make all the difference in the world. I so totally agree that, there's just nothing more beautiful than getting to know an entire family system over time so that you can work with them, if they're kids, watching the kids grow up, just the whole 9 yards, and often multi-generational too, so it's a real gift, and being able to explore that with folks and just honor that piece of it all. It's kind of like you were saying earlier, Bill, that you need to honor the individual, but you also need to know what's going on at home. You need to think about everything from, the neighborhood and the community at large to, how the global systems of things are affecting care and how that's affecting an individual. Really, really powerful stuff.
Both of you have mentioned in different ways the idea that we have scientific basis for recommendations that we make. And I remember, Bill, a few years ago, you came across an article that showed how much of the recommendations, what's the percentage of the recommendations that we make in conventional medicine that's actually based in solid, hard science. I remember you gave me the statistic, or you asked me what I guessed, and I guessed wrong. and then you told me. Do you remember?
I can't remember, but it was low.
It was low.
A third, maybe.
Yeah, it was.
Do you recall?
I think it was about 37%. Adam, do you remember this statistic?
I've seen different numbers over the years, but yeah, it's usually surprisingly low. Just this idea that we're always gathering research, and that that unfortunately sometimes that what we do outpaces the research, sometimes commercially and sometimes in other ways. Yeah,
it's coming back now. Oh, that's good. It's coming back because that's one of the things I've dropped, because being so angry at the system and at colleagues injured my health. And so it's like I don't want to think about it. It's about between about 34 and 40%. And that's on 3 different major studies by impeccable people, doing really good research. And the thing that really bothered me, I'm getting excited to know that they were published in major medical journals. 2 of the studies were published in major medical journals, and they got that 35 to 40% were all that had good science behind it. 60 to 65% of what we do doesn't have science really behind it. And yet the articles got almost zero publicity or looking at or anything. And so, and anytime we would try and bring up something like vitamin D or vitamin C might be helpful in something, well, our colleagues all go, well, where's the studies? And I just want to go pop them in the nose. Right?
Well, and I think that speaks to the whole idea. When I work with students and residents, one of the things I'll say is the 3 most powerful words you can utter sometimes are, I don't know. There can be a but after that. I don't know, but I'll look that up, or I don't know, but let's explore it together, that kind of thing. But just that recognition that part of this, part of being a human being is they're just things we don't always know. And just because it worked for one person doesn't mean that it'll work for the other person, because we have so many differences too, right? Genetic and otherwise. And so I think just allowing room for everybody to have a little bit of a question mark is a good idea. And what do we know? When there is knowledge, making the most of that, and then being really intentional, as a society, as a society or as societies, about where is the research going, and what do we support, and where are the gaps, and how can we maybe fill those in, recognizing that there are many ways to come to understandings of the world around us too. It's so funny. We spend a lot of time, which I think is absolutely important, looking at evidence-based medicine, absolutely vital. And, some of the best clinicians I know also are very good with their intuition. They just instinctively know, no, we've got to watch this patient. They're going to have a problem. And they may not be able to put their finger on any particular lab value or diagnostic test that tells them that, but often because of their experience and their understanding and their innate sense of things, they're very right. And so honoring that too, even as we try to learn more and expand medical knowledge.
That's what was so frustrating, is that, yes, evidence-based medicine is important, but when evidence-based medicine comes out that evidence-based medicine is not being practiced, then we ignore it.
Yeah, there's some irony there, huh?
That's good, yes.
Well, I think it has at least 2 important applications right now, this theme. One is, Adam, you're creating a medical school like no other, a medical school focused on whole health, and entering a field where there've got to be lots of different types of opinions about creating such a thing. And one of the ways that people like to knock down the idea of whole health and try to keep us within the confines of conventional medicine is to talk about, well, where's the evidence? And they don't want to look at how there's only 37% of evidence in the place that they regard as the gold standard. They want to just knock down anything that's not in that place where there's all that power right now. So that's one area that I think would be interesting to explore together. And the other has to do with the pandemic and what we're learning about the virus, the coronavirus, and what we're learning about vaccines. And so I'll just open it up to both of you on both of those subjects.
Well, one thing that I've loved, is I've had a chance, and this lovely group of people I've been working with have had a chance to kind of explore how we might weave whole health into medical education, right? Or base medical education on whole health, is that there are so many innovative things going on around the world in terms of what medical schools are doing and how they're branching out. And there really is a focus at many schools now to move beyond, basic science is absolutely important. You need to know anatomy, sure. But then this idea of health system science, right? And taking it beyond where you're actually looking at the health system and how innovations and technology and, the kind of the social determinants of health and public health, all those things are given real importance and priority as well. And so I feel really heartened thinking about this, and thinking about the medicine of the future, thinking about the doctors and other professionals of the future, because I think there's some real dedication to trying to grow and explore this. And so much of it is that willingness just to, think outside the box, right? And I think that's happening more and more, which makes me really happy. When I think about it in terms of next steps, I mean, it's really interesting, right? We're in an era where we talk about values-based care, and we're in an area where we're talking more and more about where is artificial intelligence going to come into play with medicine, and that whole idea of decentralizing the role of a physician in a lot of these encounters, and bringing in more of the team, or doing group visits or shared medical visits, that kind of thing. And anyway, it'll be really interesting to see where things move forward and how that'll potentially facilitate some of the things that we've been talking about, and maybe in some cases make it harder. I don't know. So I find that really interesting to ponder it out.
That's a really good comprehensive answer, Adam. Thanks. And it reminded me of an idea I've had for about the last 10 to 15 years, that the primary care practitioner of the future will be the health coach. And it's going upstream. Instead of waiting till the person gets sick or coming in for these sort of useless routine yearly exams, you have every family, just like so many families now have they go to one grocery store, or they have one tax person who does their taxes, or they have one minister who, or rabbi or priest who takes care of their spiritual, sort of their spiritual leader. Well, I think that the health coach will be that person who sort of who comes to the home periodically and knows the family and gives continuity of care, and then would refer out, help the family know when to refer and when to use the medical system. But they would, all the stuff Adam just mentioned, the ACE scores. If we just changed the adverse childhood experiences and brought up those numbers from an average of 4 or 5 to 8 or 9, you'd get rid of tens of thousands of medical problems. And the same with the social determinants of health. Those two things, the adverse childhood experiences and the social determinants of health, have been shown over and over again to just be totally related to. And so the question is, where does the MDDO come in? Is it at the end to sort of replace HIPS and do that stuff? And I think the answer is yes. I think we need to almost be over in this end with a certain type of training, and then let others either train them as really in primary care, like family medicine tried to do but got sucked into the system, or train them as health coaches or those kind of things, to really be out there in the community working with individual families to, as not racing in with first aid, but really doing preventive whole health care.
Yeah. Well, that's one of the things I love seeing the whole health piece moving forward in different groups, is there is a whole health coaching certification now. So folks who specifically coach around the whole health approach, and it's been really fun to see that blossom, especially in the VA so far, and I think other groups are going to be coming soon doing that, through the Whole Health Institute and elsewhere. And just that ability to kind of have a person, even before they're in there with their clinician, really taking that moment to pause, right, and ask, what do I really want? Why is my health important to me? What do I want to be able to do? What's important in my life? And so having someone who's there with you along to do that and to help you set some initial goals and that kind of thing can really, I think, be powerful. So yeah, it'll be interesting to see how that continues to trend. But I agree with you, Bill. I think we're going to see some pretty remarkable stuff happening with coaches.
I'm part of the VA system, and I was really impressed last year when, for a yearly exam, they said, well, you can come in here or we can send a nurse out to you to do the exam in your house. And I'm going, okay, I'll have her come here or him, And so that it was, I thought there we're getting into, and she did not do quite the look, quite the environmental type of thing that I would have liked her to do. Mm-hmm. It was more like I was in her office and she was just doing the me exam and not sort of thinking, well, is there mold in the house and how are your routers for electromagnetic field problems? And, those are the stuff that are really causing problems with people. And it's interesting because it goes back to my very first experience of why, in a sense, I became holistic when I go into the bedroom of my asthma patient and, his asthma is from the mold in the house. And so much of what we're seeing in our offices relates to what's happening in their lifestyle and life. And that's, I see, and so the question is, where should physicians come into that play? Where do we go?
Mm-hmm.
So it sounds, Bill, like you think physicians ought to be sort of toward the end of the line when there's an identified issue that they should be helping with. Am I correct in hearing you say that?
Yes, you're good, Catherine. That's right. I sort of have, all this training, and then we aren't very good at doing what I would call whole health preventive primary care. Because we're more trained in diseases still. The family medicine residents here in Minnesota, I love our programs, but they spend 18 months basically in the hospital of those 3-year residency. And yet most of them are not even going to have hospital privileges. And when I talk to the directors, they say, well, you've got to know the serious disease to take care of that and the milder. And I go, no, you don't. You don't have to know how to, do the other stuff very much. And so, I think the whole training program of my specialty, in which I love family medicine, is still based in the same way I did it 40 years ago. It's 18 months in a hospital. And not nearly enough time in continuity of care, outpatient practice.
Adam, do you have a similar sense of where doctors ought to be in the spectrum of the patient's experience?
Well, I think a lot of it depends on what we train them to do, right? And so as we're kind of exploring how medical education looks, in the future and all of that, I think there's a lot of room to kind of do some reframing. I think that the idea that the main responsibility of all the care has to be on one person is probably not necessarily going to be the case anymore, right? It's about teams and teamwork and really importantly communication among team members, right? Whether they're specialists or primary care or members of the primary care team or the coaches or all these different things. And so I guess from my perspective, I really see the physician as bringing a certain amount of expertise into play. What that expertise looks like will probably continue to evolve. But then I think that there are going to be skill sets that we can't even imagine right now that we'll expect MDs and DOs and others to offer, as it all moves forward. So I guess I see it maybe as a little more, not just at the end stage, but just that it looks like primary care as it can be in its best form, or integrative health in its best form, where you've got maybe some of the role of coordinator, or the sort of like knowing where to send people starts to come into play more for that. I feel like that's certainly been my role over the last 20 years or so in doing my primary care practice, has been kind of like figuring out where best to build bridges for people, and I really enjoyed that role. And then doing some of those pieces myself. But I think it'll depend a lot on the system and on the physician or on the way that the team plays out. I will say that, one of the buzzwords I'll use talking about whole health is it takes a village. It's not something that you can just say, oh, I'll just start doing whole health by myself and add it to my practice and everybody will live happily ever after, because it's not something that just happens in one visit a year. If you're setting goals with folks and you're following up with them about that and you're coaching them along the way, it requires a team. And I think that's a beautiful thing, because I think that people need that network of folks who help them out and have different perspectives, and also hopefully can have some degree of being on the same page, so it feels like there's some consistency. So,
Catherine, your specialty of primary care internal medicine, I think really speaks to my point, which I've been seeing for a long time. Right now, 2 years ago, the last statistics I saw, above 100 trained internists, 50 become hospitalists, 40 go into a subspecialty. 50 go into a subspecialty, 40 become hospitalists, and only 1 out of 10 go into primary care. And I see the same thing happening in family medicine, because our training is in the hospital. And so many of them are now becoming hospitalists or family doctors also. And I don't feel family medicine, my specialty, is doing a good job of training primary care doctors to be out of hospitals in doing primary care. It feels to me like way too much time in the hospital. And acute care fast medicine is very different from slow medicine and chronic care. They're really different things. And it doesn't make me that much better a doctor to have spent half of my 3 years of training in a hospital taking care of ICU and other patients, I feel.
I think we all know that the reason the training has looked the way it has is largely economic. It's how hospitals
Right.
manage to have cheap labor in the form of these interns and residents. What I'm really curious about, and I'd love both of your thoughts on this, is, I'm a big believer in teams and teams working together and collaboration, and you guys know this about me. It's why Living Whole Online looks like it does. And I also know that without a strong leader in the team, some teams can work pretty well, but a lot of teams don't work well at all without a leader. And maybe I'm speaking now from my prejudice of having been trained the way that I was in internal medicine and primary care, and having been trained by people in the generation just a little older than Bill. One of the most memorable things somebody in that generation told me when I was a young medical student was, Catherine, 90% of what you need to know from the patient, you're going to learn from the story that the patient tells you. So learn to listen really well. Learn to listen to everything, not just the words they're saying, but listen to everything. And back then I had no idea really what he was talking about. But over time, I kind of caught on to this more broad way of listening that he was alluding to. And so whether we're going to train physicians in this art of really listening, or we're going to train health coaches, or I don't know who we decide, but whoever it is, I think that person has to be thought of as the team leader. And one of the things I remember learning as an intern from a senior resident, we were on call overnight, and somebody came in at 2 a.m, and I was super tired, and the woman was elderly, and there were 4, it was back when we had paper records, there were 4 folders of paper this thick, and my senior resident said, you read every page, because there's going to be mythology in this thing. And one of your jobs is to find the truth. Because when somebody writes something, then people get They look at that and they just write it in the next note and the next note. So your job is to go back and find the real stuff that's going on with her. And it was one of the best lessons I was ever given, because back in the very first folder, the oldest one from when she was, decades earlier, were the real clues of what then helped us know what was going on with her that night, which she was a mystery. We couldn't understand what her symptoms were from the presentation that we had. But by excavating through all of those records and being able to read them and understand them, we were able to solve that mystery. And that became a real guiding principle for me as I practiced medicine all of these years. So, when we start talking about teams and people, trained in various areas, that's the place where I get stuck. When I think about not having physicians, or at least people trained like physicians used to be trained, who can come in and kind of put their arms around the whole picture and really, really listen, not only to the patient, but to the family. Ideally, yes, go to the home. Get a full picture. Then once you have the full picture, then you can say, okay, I need the nurse to do this, the social worker to do this, the policeman to do this. There's this giant team of people that can be helpful in all areas of health. But somebody has to have, what I think of as this holistic and extremely well-trained way of assessing things. What do you guys think about that?
I think at some level we're saying the same thing. The person, I guess it's just a matter of degrees. I see the person out here as the primary care practitioner trained very differently, not needing to be that person who comes in the hospital. See, it's already happened. Primary family physicians don't even go in hospitals anymore in most of the country, and neither do primary care internists. But that doesn't mean that if you're my patient, I've known you for years, I would communicate with that hospitalist. And see, but even there, the hospitalist, even if you're in the hospital, I don't know if you've been in the hospital lately, but you'll get 3 or 4 different hospitalists. You don't even have one hospitalist even in your 5 days in the hospital, because they're on 12, 24-hour shifts and they're off all the time. And so what you're talking about is an ideal system, but it isn't going to happen. That's sort of the old, where all of us practice that way. We sort of knew the patient. We came in, we might get consults, but we were the guiding light. But I don't know. I still think that the primary care practitioner could be the well-trained primary care person, but working in closely with the health coach, and the two of them as sort of the team. That's what I go for. Your new system down there, your new medical school. What I know is we need training in a whole different way, and this discussion should probably be being held in 20 or 50 or 100 places, and then and coming together with what is the best way we should be training. And maybe Adam, at your medical school, you're going to be doing that, figuring out how to do it. But yeah, I know if you start just doing it the same way we've been doing training, that it's the country's changed, and medical education hasn't changed that much.
Any thoughts on that, Adam?
Well, it's so interesting, right? Because of course we want to make sure that we're meeting accreditation standards and everything, and leaving room to help students, be able to succeed in residency and all of that. And then, trying to bring in some of these maybe new concepts in some ways, or at least emphasize concepts that people know, but maybe they haven't been fully emphasized before. And it'll be interesting to see where that goes. I think that the model itself is continuing to evolve, just as healthcare is continuing to evolve. I guess one thing I'll say is that, ultimately we're in a time and a place where we've seen just how much it matters to have care for the caregivers and to think in terms of chronic disease models, and to, given so many things that have gone on, the social and structural determinants of health, that it's just a matter of how we change. I don't think it's a matter of whether or not we'll change. And so I'm really interested to see how that'll unfold. Part of what we need to do is, I talk about empowering and equipping patients, but empowering and equipping healthcare professionals, clinicians, whatever, to be able to lead the charge or to think about this. If you're so caught up with your head to the ground, just trying to churn through or do a throughput model, it's pretty hard to be innovative. And similarly, I mean, even just the things that I think of that just weren't kind of completely covered in my own medical school experience. We had 2 weeks of nutrition, but that's so fundamental, for example. Or, there's so many physicians who find themselves in these leadership and teaching roles, but they might not have gotten any formal training in how to be an educator or how to focus on advocacy or on how to be a leader. And so how can we bring some of these skills to bear so it's easier on folks too, And I think one of the most important ones is skills at self-care. Self-care is also a skill. And it's certainly not a skill that's always, it's gotten better, but it's still not a skill that if you look at most medical schools, websites, it's not necessarily front and center, and so how can we change that and honor that part of what we're doing is trying to bring it forward in a way that I just always think of the study back in academic medicine in 2008, where they looked at empathy levels for students over their 4 years of training, and the number just plummeted over the time. We shouldn't be taking people's empathy away when we train them. And I think a lot of folks have been investing a lot of time and energy to make sure that doesn't happen, which I'm really glad about. And we can continue to do more, because that matters. So I think there's a lot to be learned and a lot to do. And I think there are a lot of unknowns, and that's okay. I mean, there are always a lot of unknowns. That's kind of why we have the scientific method. That's why we explore new models and then realize maybe that while we're exploring that model, it's going to change. It's a very iterative process.
Adam, that's a really good point, because one of my most terrible studies that I read was on this one where they measured empathy in medical students on the start of freshman year or first year, and at the 7 years later at the end of residency, peds, internal medicine. And I mean, it was like it was at 80 or 90% level, because you can measure empathy on testing pretty well. And it was, it's up at 80, 90%, and it was down at 30% by the end of residency. And that study alone should have been either repeat it 5 more times to make sure it's right, or we should have really looked at that and said, what kind of physicians do we really want to train here? It's, and it's one of those studies that just got ignored. I want to follow up on what I said. I think why I'm so passionate about family physicians, at least, doing too much and being trained way inappropriately is I started a rural family medicine residency, and I had to leave after 3 years because the Academy of Family Physicians insisted that I train all my residents in colposcopy, in vasectomy, in delivery, and I had a 4-4-4 program. And like my first year, 2 of my top residents knew they weren't going to deliver babies. They wanted to be in family medicine, but they were going to have families. They didn't want to just, they didn't want to do that. And I thought that was totally appropriate. One of them was my niece, a superstar student. And so here I am forcing her to take all these months of obstetrics when she's never going to deliver a baby, having to teach her vasectomy and colposcopy when I don't think in general, unless you have extra training, that it's what we should be doing. Because every study done shows the more you do of something, the better you are at it. And as a family physician, I know how many colposcopies and vasectomies I'm going to do. It's very few. And so here I am having to train them. And I argued with the Academy of Family Practice. I argued with the Board of Family Practice. I argued with the University of Minnesota, and I lost. And so I quit. I loved doing the job, but and I think I probably haven't gotten over it, that I'm going, this is crazy how we're training family physicians to do so much. And I know, Catherine, you have this thing about being the leader of the team, and we need this person who sort of brings it all together. I think there's other ways to do that. I'm not sure the physician is the absolute best person to do that. or the primary care physician is, and then let that person connect with the hospitalist, and sort of help them run the case or something. But I'm hoping, Adam, that your new medical school can really look at this stuff, because it's like sometimes I look and it's like we haven't changed medical education in 50 or 60 years. They're pretty much doing it the way I was trained, and yet medicine has changed so much. And
yeah, it's interesting. I think about it, in terms of like the model of a ship. So the patient's the captain, right? The person's the captain of the team. And then who helps coordinate that for him? Who's the first mate who's taking their orders and making sure that the ship's running and supporting them all along the way or whatever. And I think there are a lot of ways you can do that, but it takes crew, and maybe it varies from person to person a little bit in terms of their preferences. So
yeah, your specialty, Catherine, the family of internal medicine, as I mentioned, I think it's like it's trying to tell us that we need to train differently because internal medicine doctors don't go into primary care. That should be, we should have bells going off of when only 10 out of every 100 go into primary care. And yet general internal medicine was sort of what, we think of as the internist, as the leader of the team.
Yeah, the ship being the patient. One of the talks that I've put onto Living Whole online is called "The Doctor is In," kind of off of the Snoopy Peanuts comic strip where Lucy had "The Doctor is In" for her psychiatric practice, but the doctor is in. From a practical point of view, especially given how people have been the past 80 years relating to the conventional medicine system, many people are not equipped at all to be the ship, be their own doctor. They don't have any ability to do that, any education, any way of sort of even orienting themselves in that way, because they've been trained to give over their authority to somebody else. And all of us, we're in that system helping to train people to give their authority over to us. Whether they do it to doctors or they do it to a religious leader or they do it to, whoever. There's this idea that I'm here and these professionals are here. So we're talking about a giant paradigm shift to say the doctor is in and you're the one assembling your team, or I am a ship and I'm the one assembling my crew. That's a really, really, really big cultural shift, and it's certainly one that I buy into wholeheartedly. And at the same time, when somebody comes with a set of very complex symptoms, you need somebody extremely well trained in not only understanding health and healing, but also able to listen very well in order to try to sort through everything. And so it's one of our many challenges as we shift this paradigm. I'm with you guys 100% in terms of we have to change the paradigm. And Adam's really good at framing questions with the word how. How are we going to do this? How are we going to do that? But there are some things that are just sort of fixed. Like human bodies have stuff that goes well and stuff that doesn't go well. And we have to be able to sort that out and be trained well enough to know what that is. So, any thoughts on that, either of you? How we go about that?
That's what Adam is now doing in his new medical school.
Yeah.
Well, it's a work in progress, and I think there's going to be a lot to be discovered. And as I approach it all, I just try to go in with the understanding that we're learning a lot. And to try to go in and say that I or my colleagues who are doing this design work know specifically what we need, that's not appropriate. It's something, like I was saying earlier, that'll be iterative. But there are things that I think we can leave room for, and certainly things like, looking at the whole person, building care around what matters to folks, thinking about empowering people to do their own self-care, having the resources, all of those different pieces. And then recognizing that in order to do that, we need to have faculty and people who get it and can model that, right, so that the students can continue to grow, even and grow beyond medical school too, is really important. So yeah, the how is still a big question, but I just love that it's a question we're asking.
Yeah,
I think that's really important.
it is. It's the most important part of the question is, how are we going to do this? Because then it opens it up to all the different possibilities. And self-care, I am completely in agreement with you. For those people who will engage in self-care, and that's really what Living Whole Online is about, come on in and have a lot of experiences that will help you with your self-care and your wellness practice. For those who will engage in self-care, there's a certain way that we can build the new medical system, the new health system around them, because they are more likely to step into the idea of I am the ship. And then we also have to think about how do we build a health system around people that don't want to do anything for their health. They don't want to do any self-care.
Getting back to meeting people where they're at, it's not something you can force, but always circle back and ask.
Yeah. So I guess my final question, since we're closing in on time, is what do you both see Living Whole Online doing for all of us at this time in history, during this pandemic, during this time when we're making this large paradigm shift in how we think about the medical system? What are your thoughts on how Living Whole Online fits into
that? I think it's coming in at a perfect time, because I think the whole world and everything we're doing is changing dramatically with the pandemic. We're realizing that so many workers can work at home. Education part of it can happen at home. And so my idea that I brought up at the start of this little talk here that we're doing was we need more health coaching. And Living Whole Online is basically, I see, the perfect metaphor for what health coaching can be. Because health coaching at its essence is looking at our mental, spiritual, social, ecological, all that different stuff. And that's the kind of programming and kind of lecturing and kind of interdisciplinary stuff, movement, all that stuff is what's going to be on the Living Whole Online. And so, in a sense, I see it as the universal health coach, because education of who we are as people and being able to make individual choices is the key. And instead of having, I see it also, the next step would be then people who want it then would have availability to a health coach who could virtually do it or in-house, either one, in person. But this is sort of helping all these people attain a higher level, a better degree of health than they could do on their own. And it's like the public school education system. It's going to try and educate all the people to how to be more healthy. And I think there's, a lot of people really are interested in that, want to learn, want to take charge of themselves and try to be more healthy themselves. How about you, Adam?
Yeah, so, certainly I want to be as inclusive as possible for different organizations that can support this. But my perspective is that there's a huge hunger, with people wanting to explore this and maybe not enough opportunity to do that sometimes. And so, providing venues where people can learn more from this, multiple different perspectives is so key. And so anything that we can offer where people have a chance to do that and to do it in a way where they feel cared for and understood, and where there is that space to, do kind of that inquiry around it all, and come to understand things better so that they're empowered and equipped is great. So I really love that intention.
You've said empowered and equipped enough times in this chat that it's now become a little bit of a mantra for me as I say goodbye to you guys. And one of the things that is very important about becoming empowered and equipped is having experiences. Just having experiences, and this is what you did for so many years in the VA system. You gave people experiences, and it's what it seems you intend to do with the Whole Health Medical School. It's certainly what we intend to do with Living Whole Online. Once people have experiences, then everything shifts for them. So then, that little barrier I was talking about earlier of, really, the doctor is in, or really, I'm the ship. Once they have the experience, yep, I'm the ship. I feel like I'm the ship. then we can move in a completely new way.
Yeah. So. Yeah.
Adam, when do you start your first class, and how many students will be in the first class?
So 2024, the fall of 2024, and somewhere between 40 and 50 to start out, and then it'll likely grow. It's still all kind of to be determined, but yeah, that's the thinking so far.
So you mean you're 3 years away?
Yeah.
Oh my gosh! Whoa. Huh.
It makes me think about little kids, who say, "Oh, I've always wanted to be a doctor ever since I was 2." We've all met people like that. Maybe you guys are like that. I wasn't like that.
No.
But you can imagine talking to somebody who's in like 7th or 8th grade right now and saying, "Hey, there is going to be this really, really cool thing." When you get to be a little bit older, keep an eye on this place.
Yeah, it'll be interesting to see how that all plays out. Yeah, amazing how many different factors go into exploring this, and creating it. But
so why is it going to take you 3 more years to set up the medical school?
Well, it requires a building. It requires accreditation with the LCME and the various groups and state and national that approve higher education programs. It's hundreds and hundreds of pages of materials that are required in order to show that we're going to be doing well by the students and doing well by the faculty and doing well by the whole 9 yards. So yeah, actually it's funny because it seems like it's not much time.
That's what it seems like to me. Only 3 years. Oh my gosh.
Yeah.
Well, they only gave me 1 year to set up the family medicine residency, so that's why it seems like a long time. But I think a medical school is a lot more complicated than a family medicine residency.
Yeah, you had this.
There are a lot of layers.
Yeah. Well, I want to thank both of you so much for being with me today. It's so wonderful to have you as colleagues and international integrators and as part of Living Whole Online and as part of all these other things that you do in the world that are so important and helping so many people. So thank you very much.
You're welcome, Catherine. There's no 2 people I'd rather be with in the world than the 2 of you. So anytime, I'm glad to do it.
Nice to talk to you guys.
Nice to talk to you.